introduce David Gatz is an assistant professor at University of Maryland, trained there and then was a chief resident and now is the assistant medical director. And he's been trying and making a niche for himself in transplant emergencies. I know most of you guys don't like taking care of transplants because I get all those phone calls. So hopefully we'll get people a little bit more comfortable in how to care for them and stabilize them. Give me 1 second.
Perfect. That's coming through. Awesome. Well, it is great to be here, and I got to say I'm really excited to actually be here for an in-person lecture. So I'm disproportionately excited to finally have this opportunity. So thank you. Again, my name's David Gatz, as mentioned, at the University of Maryland, and I want to talk to you guys for a little bit here about the management of solid organ transplant recipients in the emergency department. Now, full disclosure, we cannot possibly cover everything transplant related in the next 25 to 30 minutes, not even close. We're not going to try to do that. Instead, what I want is just for you to kind of walk away from this with sort of 3 key points. And we're going to go over these a couple times during this lecture. Number 1 is really simple, which is just why. Why should we as ED clinicians spend some time focused on the care of these patients? And building off of that is sort of part 2, which is what are the 2 things that make this population so unique? And as a result of that, finally, how might our differential or management of these patients be affected when we're evaluating them in the emergency department? So this is where I work, University of Maryland Medical Center, our sort of academic hub for our medical system. Now, as a medical system, we do a lot of transplant surgeries. In fact, we do over 400 solid organ transplant surgeries per year, which means we get to see a lot of these patients in the ED, but also just kind of opens up the general question of how do we get to this point as a society where we can do this many transplant procedures. And certainly the amazing work of our surgical colleagues is a huge part of that, and this is not to minimize the work that they do, both during the operation and immediately afterwards. But at a more fundamental level is something smaller but perhaps even more significant, and that is immunosuppression. And this is something we're going to come back to a couple times during this talk about the role and significance of these medications. But right, this is why we don't have to have a perfect match. This is why you don't have to keep your identical twins safely tucked away in your basement in the event that you need a kidney transplant later in life. Because of these powerful medications, we can have transplants successfully between family members, between friends, between complete strangers, and still have great outcomes. As we've gotten better with these medications, not only are more people eligible to receive a transplant, we're also seeing graft survival longer and longer. And importantly, that means our patients are living longer and longer. So what's the net effect of this? We have more people eligible to receive transplants. Those individuals are living longer and longer. It means the total number of people in developed countries like the United States who have received a solid organ transplant is continuously increasing, even throughout the COVID-19 pandemic, which makes it inevitable that all of us will be seeing these patients in our emergency departments. So whether you're at an academic center where you're seeing multiple such patients per shift, or even a rural critical access hospital, these patients are going to be coming into your ED, and there are just some basic things that we need to know and be thinking about in this population. So just to briefly touch on who are we likely to see, what are our most commonly transplanted organs, certainly kidney and liver make up the majority of organs, and this makes sense, especially for kidney where you can have living donor opportunities, the same to a lesser degree of liver transplant. Not so with things like cardiac and pulmonary, but obviously still an important population as well. Kind of beyond the scope of this talk, you can see things like pancreas, small bowel transplants as well. So that's, again, just why we need to spend some dedicated time on this. So what are kind of the 2 things that make this population so unique? We're going to explore this with a case. So this is based on a patient that I had. So this is Deborah. Deborah checks into the emergency department because she's having some dyspnea. Most notably, as we look through the chart, we see she does have a history of a cardiac transplant. So as we start sort of walking over to her room to sit down and talk with her and go through her history and her exam, what are some of these things we need to keep in mind? Well, first is one of these things we already touched on briefly, which is her immunosuppression. And what I want to emphasize here, and I'm going to say this a couple times, is the significance of her immunosuppression goes well beyond just preventing rejection. And we'll get into that momentarily. The other part of this is just the anatomical and physiologic consequences of transplanting an organ. It turns out when you literally cut an organ out of one person and put it into someone else, it doesn't behave in the exact same way. And the heart is a great example of this, as we'll get into. But let's start with the immunosuppression. So what do we need to know? We don't want to be like clueless talking to our patient as we kind of go through these medications. So we want to know, what are you taking? Are you taking it? These are important things. But what kind of is the fundamental knowledge that we should have here? So regimens can vary, but in 2022, probably the majority of our patients, that foundation of this immunosuppressive regimen is going to be a calcineurin inhibitor. So your medications like tacrolimus. What I want to emphasize here is that each of these medications have side effects significant enough to actually individually result in that ED presentation. So it's not always directly related to the organ. We need to be thinking about these drugs. So what is that for something like tacrolimus? Things like nephrotoxicity, or even a couple months ago I had someone come in with neurotoxicity associated with this. So headaches, tremors in their extremities are some of these symptoms that we'll be looking for. This can be paired with next, most typically an antimetabolite. So this is your MMF, mycophenolate, or so your medications here. Again, significant side effects. The ones I see most commonly are going to be gastrointestinal. So if someone with subacute diarrhea coming in with that. And then finally, this can be paired at times, often with a low-dose steroid, typically prednisone. Obviously, you guys are well aware of the many side effects that can come with long-term steroid use in that case. Big picture, what do I want you to take away from this? Oftentimes, our patients are going to be on their highest immunosuppression shortly after that transplant. That's when the risk of rejection is highest. That's when they're going to be on maybe a triple drug regimen. As we get further out from it, closer to that 6-month range, that's where we're trying to wean off to get to the minimum level of immunosuppression possible while still preventing those episodes of acute rejection. So if you have a well-matched kidney, for example, in terms of that HLA matching, you can get down to monotherapy where your patient may only be on tacrolimus. In our patient's case, Deborah, right, she's a cardiac transplant. Very rare that you get HLA matching there. It's just sort of you get what you get when it comes along for that sort of a thing. So much more likely that she's going to be on a more significant course of immunosuppression for her entire life. So some of the things we talked about with immunosuppression, side effects, we need to pay attention to them. Drug-drug interactions, certainly possible. I don't expect anyone to memorize all the possible drug-drug interactions. Just know they exist, right? If you're starting a new medication and someone who's already on one of these, you can easily check for those sorts of interactions, like a calcineurin inhibitor and a calcium channel blocker. Just know that interactions exist. Obviously, as we dampen down the immune system, the risk of infection is going to rise, but also recognize that as we dampen down that immune system, so does the risk of malignancy. As these patients are living longer and longer, malignancy is actually now one of the leading causes of death. So if they report, something like a new skin lesion to you, we can't just completely dismiss that, because things like skin cancer are super common in this population. We need to make sure they get appropriate outpatient follow-up for that sort of a finding. So we're talking with Deborah, we go over her medications. It's now time to kind of move on to her exam. We take a look at her vital signs. Not too bad, maybe a borderline temp, but we see that heart rate's a little bit high at 110. Is this something that we need to be worried about in this patient? Well, this is where we kind of get into that second thing that makes these patients so unique, which is there are consequences of having that transplanted organ. As we cut all of the connections that were initially there, right? Blood vessels were obviously going to reconnect. We can't make those same reconnections with things like the nervous system. And so we see the consequences of that. We lose the vagus nerve, we lose that parasympathetic innervation, so we're going to have a higher resting heart rate. 80 to 110 is going to be normal. Additionally, these are patients who aren't going to respond to stress in the same way. So if they're sick or even exercising, right, their heart rate's not going to escalate in the same manner that we'd expect. Similarly, we've cut sensory nerves. So if they're having, say, an ischemic event, right, this isn't going to be someone who's 7 months out because this is a healthy heart we put into them, but later down the road, there's a good chance they're not going to feel those classic anginal symptoms. You're going to be looking for some of these atypical symptoms, maybe dyspnea, for example. Additionally, you're going to see some altered responses to medications for the same reasons we just talked about. So things like vagal maneuvers, not going to work in these patients. Adenosine, you're using lower doses. You may actually see a more robust response to some things like pressors. All right, so we've got that sort of context to work with. As we start talking more to our patient, we need to think about what could be going on with her. And we get a little bit more history here. She's got this dyspnea. She's got, say, a subjective fever, the vital signs we already looked at. What do we need to be thinking about in terms of our differential? And this is what gets the gears in our head turning a little bit. And this is kind of the key thing that I just want you to take away from this talk, which is no matter what the presenting symptoms are, always ask yourself, is there any way for this patient that these symptoms could be related to infection? Could they be related to rejection? Could they be related to some sort of organ-specific surgical complication? And with this subjective fever that she's giving and the dyspnea, it makes sense. We're going to explore infection, certainly. So what do we need to know about infection in transplant recipients? Well, classically, we see infections occur in 3 distinct windows. This first one are these early phase infections, so they occur in the first 30 days. We're thinking nosocomial infections, your CLAPSIs, your CODIs, your ventilator-associated pneumonias, your surgical site infections. I wish I could tell you didn't need to worry about these, but as we see surgical skills advance more and more, we're talking about patients who get a transplant and are discharged from the hospital within days, not weeks. So if you're working in a transplant center, you can certainly still see these, hopefully not as much out in the community site. But as we get further out, this is where we see patients increasingly present to emergency departments other than the site that they received their initial transplant. So our second window is this intermediate window, kind of 1 to 6 months. This is when our immunosuppression, again to prevent rejection, tends to be at its highest, which means classically our risk of an opportunistic infection is also at its highest in this time frame. Kind of beyond the scope of this talk is now we have a lot of great prophylaxis regimens, so we don't see these appearing quite as much. Things like CMV, BJP, these are going to either occur not at all or they're going to end up showing up later, is more typical these days. As we get further out into our late phase, this is when we've minimized our immunosuppression to the lowest amount that we can get. Now we're looking more at community pathogens. So respiratory viruses, COVID-19, community-acquired pneumonias, that's more what we're looking for in that window. Sepsis is common. This is where you get to flex your ED doctor skills here, in particular because it's going to be sometimes subtle or occult presentations, right? Because of that immunosuppression, because their vital signs don't necessarily respond in the same way, they may not get that obvious fever. They may not get that obvious leukocytosis. They may not have obvious imaging findings on some of these, like a plain radiograph, for example. So we just have to have that sort of lower index of suspicion for these patients. So we've examined Deborah. We've said, okay, infection's possible, but we're not sold on it. Let's start thinking about what else could be going on. And again, we emphasize this differential: infection, rejection, organ-specific surgical complication. Let's explore rejection for a second. So what does rejection look like in an organ transplant recipient? Well, understandably, it's going to vary by organ. Most typically, you're thinking about what does organ failure of that organ look like. So in a cardiac patient, right, things like orthopnea, dyspnea, peripheral edema, that adds up. But it can also be things like you get issues with your electrical conduction. So if they have new arrhythmias, for instance, new onset AFib, that can actually represent rejection in that patient. So palpitations, syncope, these are also things we're going to hone in on. Unfortunately, diagnosis of rejection in the emergency department, probably not going to happen. It most often requires a biopsy, which I'm hoping most of us are not doing in the ED, and I haven't used a microscope in years. So we're not going to make that sort of a diagnosis here. We can get some laboratory tests that hint at that, but none of these are going to have the sensitivity or specificity to nail that kind of a diagnosis. So in a cardiac patient, looking for an elevated BNP or troponin, or if you've got awesome echo skills like lean, looking for some of those abnormalities, new global hypokinesis, something like that, can also be suggestive. Kidney transplants, creatinine electrolyte, leukesterase, obviously transaminitis in a liver transplant recipient, and an otherwise unexplained eosinophilia in a lung transplant recipient. These are, again, things that can suggest, but are not going to be diagnostic for us. The one exception let's say we're talking to Deborah and she says, you know what, doc, I actually have stopped taking my medications. And I wish I could say that this doesn't happen, but we've seen it multiple times where someone says they've just stopped taking for whatever reason, just complex issues. I'm no longer taking my immunosuppressive regimens. Then you actually get to make that diagnosis of acute rejection in the emergency department. And obviously this can be really, really critical. So if you have, again, that well-matched organ, we're on that monotherapy, they can probably go a few doses without their immunosuppression. That cardiac transplant recipient on three different medications, they can't miss a single dose of that stuff without having rejection set in. So this is going to be a significant emergency. We're going to talk to their transplant team, communicate with them. They'll help you order some pulse dose steroids. The exact agent, the exact dose is going to potentially vary depending on institution, the specific organ, but they are there 24/7 to help guide you through that situation. All right, so we get to close the book on Deborah. We learn that she has acute rejection because unfortunately she has stopped taking those medications. So we move into our next room and we meet Sam. Sam is presenting with syncope, also reporting some right upper quadrant pain. Notably, he has had a liver transplant 7 months ago. We see his vitals are a little borderline. He's also a little bit tachycardic, but a little bit soft in his blood pressure. So this gets our interest. We're a little bit concerned here. And of course, you guys know the process of elimination here. We're going to start looking at some of these organ-specific surgical complications. It is not possible to memorize every surgical complication for every transplanted organ. It's just not realistic for us to keep that in mind. So big picture, what do I want you guys to kind of take away? Obviously, whenever we take an organ and we put it in someone else, we're having to cut a lot of those connections, be they veins, arteries, or some other conduit such as urinary collection system, biliary collection system. Everywhere where we're reattaching those, we have that anastomosis, and that's where these surgical complications can happen. And so anywhere where you have an anastomosis, right, that can get pinched off or blocked. So whether you have hepatic artery stenosis, huge problem in liver transplant recipients, or some sort of thrombosis, like a portal vein thrombosis, significant problem. On the other end, you can have things that are expanding, so aneurysms, pseudoaneurysms, those are going to be significant, or potentially leaking around that anastomosis. So if you see a new fluid collection in your transplant recipient, whether it's a collection of bile, a collection of urine, a collection of lymph, maybe a hematoma, all of those are certainly possible. Just recognizing anywhere where we have that connection, we can have some sort of surgical complication. Of course, we can't diagnose these externally. We're going to have to turn to imaging. So both ultrasound and CT are going to be our friends here. Oftentimes, we have, because we see so many transplant patients, we have transplant-specific ultrasounds that are looking at these things, right? We want to look for that hepatic artery stenosis. A transplanted kidney is in a great location where you can easily actually look at it at the bedside, look for any additional collections, hydronephrosis surrounding it. In the case of Sam, this was not one of my patients, but is based on a real case. He was rushed to CT based on those kind of concerning vitals and the way that he was looking. That contrasted imaging did show a collection at the porta hepatis, a large expansion suggestive of aneurysm or pseudoaneurysm, and extravasation of some of that IV contrast into the small bowel. They paged transplant surgery urgently in this situation, but unfortunately he started experiencing significant hematemesis and actually expired despite exhaustive resuscitative efforts. What the heck was going on? He had an infected pseudoaneurysm. These can present months down the road. It began communicating with the biliary system, which is why he was having kind of that exsanguination into the lumen of the bowels there. This is a rare event, not unheard of, unfortunately. I don't bring it up as an example to scare you into doing excessive workups of every transplant patient that comes into an emergency department, but just to emphasize that there can be very significant complications associated with these surgeries, which is why we need to just trust them. When your patient comes in and says, something's not right, just believe them in that situation. They're going to be the best person for examining their own body. So I'm going to close out with just summarizing those key takeaways. Before I do, I just want to open the floor up for any questions. I know we have lunch after this, so it's okay if we don't.
Any questions?
Excellent.
Okay.
Comments are welcome too.
I was going to say, do you know of a way that you can quickly diagnose hepatic artery stenosis or renal artery stenosis in the ED? Actually,
You can order an ultrasound. That's how you diagnose this. You order an ultrasound.
I can always ask a question, so here I am. You mentioned that there are CTs specific to looking for the transplant pathology that might happen at University of Maryland.
Sorry, ultrasounds.
Ultrasounds.
Ultrasounds, yes.
Lovely. So just to clarify, would this be motivation for someone such as myself to get this patient to their home transplant center rather than starting to do imaging in my shop where we're not really necessarily equipped to look particularly?
Yeah, no, it's a good question. And this is one of the opportunities that we have is working in, I think a lot of you have probably accessed the Maryland Access Center to help transfer patients before. And that is a common request that we see is for patients who have been transplant recipients because they can have some of those unique complications. And there are times where if truly you feel like you can't get the adequate workup wherever you may be at, that they do need to come back. I think that is an area of development moving into the future that I know sort of leadership in the Access Center is looking to how can we, instead of bringing everyone to that central location, because obviously like many places, flow is limited, it's hard to get people transferred, they're waiting days for those opportunities. How can we instead get that specialized care maybe out to peripheral sites via telemedicine, teleconsults with these transplant specialists is hopefully the direction we can move in the future.
I'm sure nobody's heard. I'm sorry, but we have no beds.
All right, so just to close this out and then head into lunch, again, 3 things we want to keep in the differential for all these patients. Is this somehow related to infection, rejection, or an organ-specific surgical complication? Things that are making these patients so unique, that role of immunosuppression, the significance of which is well beyond just preventing rejection, the consequences of those anatomical changes from transplanting an organ, and then finally just emphasizing that communication is going to be essential here. These patients have transplant teams that follow them for the rest of their lives. They are available to you 24/7. Don't hesitate to call them during the workup to figure out what's the appropriate workup, afterwards to assist with disposition. These are patients where, unlike most of the patients I feel like I work with, I know I can get prompt, regular outpatient follow-up for them, so this is really an opportunity to try and avoid those admissions when possible. So with that, I'll just say thank you. Of course, I can't end a transplant lecture without mentioning the role of organ donation. That's my contact information, but thank you for the opportunity, and we'll move on to lunch.
Thank you. Yes.